Good morning. Mr. Chairman, thank you for your invitation. It's a great honor for me to share our findings with all of you. In this speech, we will be talking about first in human experience of preload regulation with percutaneous transluminal caval flow regulation, PTCR, in heart failure with reduced ejection fraction patient. Nothing to declare. This slide shows some important heart failure features. True prevalence is likely to be higher. The prevalence increases with age from around 100% to those age less 55 years to more than 10% in those aged 70 years or over. This slide shows some important statistical data, background, and projection according to the American Heart Association. Up to the present, the approach to preload reduction in patients with congestive heart failure depends on the use of high-potency diuretics. Projection of heart failure by the American Heart Association for the year 2030 indicates that the number of cases will increase from 2% to 10% of the North American population. Heart failure background. 90% of 1 million of heart failure hospitalizations are due to volume overload. Hypervolemia contributes to heart failure progression, mortality, and high rehospitalization. Readmission rates 30% 90 days after discharge. IV diuretic may be associated with increased morbidity and mortality. 20 to 30% of heart failure patients develop diuretic resistance or tolerance. This slide shows the normal IVC diameter and its flow pattern. At the right panel, we have the normal IVC and the measures in different parts of the IVC. And the left panel, we can appreciate the flow pattern during inspiration, high flow during inspiration, and low velocity during expiration. Here we have an excellent case of hypervolemia. In this patient, we can observe high velocity flow in patients with congestive heart failure. So, which will be the best treatment to reduce hypervolemia? Present in 90% of heart failure. Total cardiac burden is the sum of cardiac preload plus afterload. The great discovery. The caval flow regulation phenomenon is a new concept to reduce hypervolemia and total cardiac burden without using diuretics. This phenomenon prevalence is 0.5% or 1 in 200 patients. You can appreciate in the right panel the fibrotic formation and the ejection produced by the restriction at the inferior vena cava. On the left panel, you can appreciate where is placed the fibrotic formation. It's in the right caval atrial junction, producing high velocity flow and restriction. Here we have the great discovery one case. You can appreciate the IVC caval flow regulator natural phenomenon. It's a similar, it's a like valve phenomenon producing regulation of the caval flow and have two important functions. Reduce preload, and when the valve is closed, reduce the pressure, the atrial pressure to the IVC. In the right panel, you can appreciate high velocity flow, indicating that there is a restriction of the flow or preload reduction. Here we have another case, and the criteria diagnostic for caval flow regulation. You can appreciate important fibrotic formation in the IVC, in the atrial caval junction, and high velocity flow expressing the flow pattern, indicating an important gradient from the atrial to the right atrial from the IVC. Here we have another case of caval flow regulator phenomenon. You can appreciate the fibrotic formation and the total occlusion during inspiration and subtotal occlusion during expiration. Inside of these echocardiographic findings, we decided to compare a group of patients with heart failure who developed caval flow regulation. Group 1 with a group that had heart failure but did not develop caval flow regulation. Group 2. Echocardiographic parameters were compared. Here we have our published in the European Journal of Heart Failure. In the group 1, we have peak flow velocity of the IVC during inspiration was 113. And compared with the group 2, was 0.71. There is important difference, and p-value was statistically significant. The AEA relation was 0.57 and in the group 1 and 137 in the group 2, producing an important difference and was statistically significant. Left atrium area was 18.37 in the group 1 and 28.68 in the group 2 without the caval flow phenomenon, and was statistically significant. Left ventricle diastolic diameter was in the group 1 with the caval flow regulator phenomenon 528, and in the group 2 without the caval flow regulator phenomenon was 659 and was statistically significant. Ejection fraction, very important point of the LV function. In the group 1, the ejection fraction was 59, and in the group 2, without the caval flow regulator phenomenon, it was 35, and was statistically significant. Okay, then with this important result, we designed reply mimicate the caval flow regulator phenomenon into artificial caval flow regulator phenomenon, a simple solution for a complex problem. In the right panel, we have the balloon. The balloon in long axis and short axis is a 5 centimeter balloon, and it's an oval shape with a ramp in order to avoid turbulence, and it's hydrodynamic in order to avoid turbulence. In the second figure, you can observe the balloon catheter in the right place to produce its regulation. It has to be before the drainage of the hepatic vein, just in the site of maximal impiratory collapse, who plays an important role in the support of the physiology of this artificial procedure, producing total occlusion during inspiration and subtotal occlusion during expiration. On the left panel, you can appreciate the caval catheter balloon and the some detail of the proximal end, and in the distal end we have the balloon in order to be placed in the inferior vena cava. Okay, here we have the percutaneous transluminal caval flow regulation via femoral vein for treating acute heart failure. The catheter is inserted via femoral vein, then it was advanced to the right place to produce the regulation before the hepatic vein drainage, and producing total occlusion during inspiration is subtotal occlusion during expiration. Here we have another video who can explain how the balloon works. You can see in the right panel the balloon inflated just before the drainage of the hepatic vein, and when it's produced inspiratory collapse, it produces a total occlusion, and then during expiration produces subtotal occlusion. Now we have how the balloon works via subclavian vein. This important approach is very useful and very important because it's the approach that we will be using for discharge the patient to home in order to go home and live with your family or your laboral activity without readmission or complication. First evaluation in human with our caval flow regulation artificial model. Given the observed evidence in the previous study, we decided to evaluate the performance of our balloon catheter in an animal dog, and subsequently began a protocol for a study in human with heart failure in our institution. Evaluation study of acute hemodynamics effect. The aim of this study was to evaluate the acute hemodynamic and echocardiographic effects in heart failure in patients who underwent coronary angiography. Our hypothesis was caval flow regulation with PTCR produces reduction of total cardiac burden. Inclusion criteria. I was more than 18 years old patient, both gender, who underwent coronary angiography. Patient with sign of angina and heart failure who were willing to participate in our study. Patient who showed sign of symptoms of ejection fraction and ejection fraction less than 40%, and high pro-brain natriuretic peptide more than 200 picograms. Patients who were receiving medical treatment for heart failure, all patients were required to sign an informed consent form. Exclusion criteria were patients on renal dialysis, patients on ultrafiltration, patients in hypovolemic shock, patients on biventricular artificial stimulation, patients with pleural or pericardial effusion, patients with valvular heart disease, patients with acute infection, patients who receive chemotherapy, and patients with abnormal renal function. Here we have some baseline demographics. We study 4 ischemic patients and 2 non-ischemic patients, 2 women and 4 men. Pro-BNP was average 129, and the renal function was normal. Here we have the PTCR in the first patient. You can appreciate the catheter balloon in the IVC producing total occlusion without flow and subtotal occlusion with flow. This first case was presented and published in Journal of the American College of Cardiology, and you can observe here the DOI, the reference, in order you can access and see the information. Here we have the hemodynamic data results. Mean right atrial pressure before balloon was 9. During balloon decreased 42%, and p-value was statistically significant. Systolic right ventricular pressure was before balloon 44, 17, and during balloon decreased to 30%, 19, and was statistically significant. Mean pulmonary artery pressure was 37 and decreased to up to 28 during balloon, statistical for and was statistical. This difference was a statistical difference. Pulmonary capillary wedge pressure was 25-50 and decreased during balloon up to 1750, and was an important reduction and percent of change of 31, and was statistically significant. Cardiac output was 4 and increased 450, and percent of change was almost 10, but was not statistically significant. With regard to echocardiographic data results, we have important information here. LV diastolic diameter was before balloon 643 to 576, and was statistically, this difference was statistically significant. Left ventricle and systolic diameter was 519 and decreased to 478, and this difference was statistically significant. Left ventricle and diastolic volume was before balloon 187, and during balloon decreased up to 160, and was statistically significant. LV and systolic volume was 123 and during balloon was 101 and was statistically significant. Ejection fraction increased from 33 to 40 and was not statistically significant. These important results were published in Heart Failure as the first in human experience of preload regulation with percutaneous transluminal caval flow regulation. You can hear the DOI, the reference, you can get the technology differentiation and competitive landscape. Our catheter balloon, caval catheter balloon, is a new technology that produces reduction of total cardiac burden by reducing preload intermittently and afterload. Our new technology is minimal invasive, low-cost device. Surgery is not needed. It is a percutaneous method supported by the patient physiology, non-clinical complication, simple technology, no battery or pump needed, and simple device for global problem. IP, intellectual property, we can say here that we have US patent granted of the method and the device, European patent of the granted of the method and device, Russian patent, and PCT WIPO granted. Japanese patent in project. The PTCR trademark was registered in New York. FDA regulatory pathway submission was introduced to request breakthrough designation. Preclinical study to evaluate safety of the procedure for FDA will be conducted at Texas Heart Institute. Conclusion. This is the first experience in 6 humans of an innovative procedure, PTCR, for intermittent preload reduction in patients with heart failure. The beneficial hemodynamic and echocardiographic changes obtained in these heart failure patients suggest that this new procedure may play an important role in the treatment of heart failure. This procedure could be useful during pregnancy and nursery heart failure because diuretics are contraindicated during such condition. Further studies are needed to evaluate this novel procedure. Peace, a necessity for humanity. La paz, una necesidad para la humanidad. Thank you. Muchas gracias.